This is A&P Live Studio. I am your host. As a registered nurse and anatomy and physiology instructor for advanced healthcare professionals, I'm glad you're joining me. Today, we're going to explore a really complex condition where the body's own repair mechanisms, well, they become the source of destruction. We're talking about idiopathic pulmonary fibrosis.
So, welcome. Our goal today is to trace the complete journey of IPF, from the cellular level all the way to the clinical picture. Understanding this whole pathway is absolutely key for recognizing, diagnosing, and ultimately managing this challenging disease.
We'll kick things off with a patient story, because that really helps ground the science. Then we'll quickly review the healthy lung before exploring how that healing process can go so wrong. After that, we'll connect everything to the clinical picture, talk diagnosis and management, and wrap up by looking at IPF as a whole-body problem.
All right, so let's connect the science to a real person. I want you to meet Mrs. Chen. She's 82, and her journey with IPF, like so many others, started very quietly, with symptoms that are just so easy to dismiss. For months, she had this nagging, dry cough that just wouldn't go away, and she noticed she was getting winded more easily. This slow, gradual onset is a classic hallmark of the disease. And for many patients, these initial symptoms can be present for 1, even 2 years before a diagnosis is made, because they're often just chalked up to getting older or other common issues.
Now, to really grasp what's going wrong in IPF, we first need to take a step back and just appreciate the beautiful, efficient design of a healthy lung. The star player here is the interstitium. This isn't just empty space between the air sacs. It's a really sophisticated, delicate network of tissue that gives the alveoli their structure. And its most critical feature? It's incredibly thin. That thinness is what allows oxygen to just effortlessly diffuse into the bloodstream and CO2 to diffuse out. It truly is the vital interface for every single breath we take.
And this comparison here really tells the story. On the left, you've got the normal lung, a thin, flexible interstitium that expands and recoils with no problem. But on the right, you can see the impact of fibrosis. That delicate tissue becomes thick, stiff, and scarred. This does 2 devastating things. First, it physically restricts the lung from expanding, which reduces your total lung capacity. And second, it dramatically increases the distance gases have to travel, which directly leads to hypoxemia.
So that brings us right to the heart of our discussion today, the pathophysiology. At its core, IPF is a story about a fundamental biological process, wound healing, that has just gone terribly, terribly wrong.
This quote, it just perfectly captures the essence of the disease, doesn't it? Think about it. In a normal response to an injury, scarring is a controlled, temporary process. It stops once the repair is done. But in IPF, that off switch is essentially broken. What you get is a relentless, self-sustaining scarring process that just doesn't stop.
So let's walk through how this happens. It all starts with these repetitive micro-injuries to the cells lining the alveoli, the alveolar epithelial cells. This is happening in someone who is genetically susceptible. In response, these damaged cells start sending out a flood of signals, pro-fibrotic signals. And the most important one here is transforming growth factor beta, or TGF-beta. TGF-beta is like a powerful wake-up call for fibroblasts, telling them to multiply and change into these things called myofibroblasts. And these myofibroblasts are the real workhorses of fibrosis, just relentlessly pumping out massive amounts of collagen. This leads to irreversible scarring that completely warps and destroys the delicate architecture of the lung.
But this cascade doesn't happen in just anybody. There's a really strong genetic component at play. The biggest risk factor we know of is a common genetic variation in the MUC5B gene promoter. On top of that, mutations in genes that are responsible for maintaining our chromosomes' protective caps, the telomeres, genes like TERT and TREC, can cause lung cells to age prematurely, making them more vulnerable. And finally, if you have defects in the genes that code for surfactant proteins, that can cause stress and injury to the alveolar cells, basically kicking off that very first step in the whole destructive process.
Okay, so we've got all this chaos happening at the cellular and molecular level. How does it actually show up in a patient like Mrs. Chen? Let's connect the dots from the pathophysiology to what we see in the clinic.
The main symptoms are a direct result of that lung scarring. The progressive shortness of breath? Well, that happens because the lungs are so stiff it takes more work to inflate them, and gas exchange is terrible. That chronic dry cough is thought to be related to the constant mechanical stress from the fibrotic tissue. And in about 1/4 to half of patients, we see digital clubbing, that physical sign linked to chronic low oxygen levels. And of course, the profound fatigue. That's just the logical outcome when your body is essentially being starved of oxygen.
When you listen to the lungs with a stethoscope, there's a very classic finding: fine, bibasilar, inspiratory crackles. And this analogy of pulling apart Velcro is something you'll hear a lot.
It's the perfect description for the sound made when those small airways, which have been collapsed by the scarring around them, suddenly pop open during inhalation.
And this brings us to a really sobering point. The prognosis is stark. With a median survival of just 3 to 5 years after diagnosis, IPF is actually more lethal than many cancers. This really underscores why getting that diagnosis and starting management as early as possible is just so critical.
So, given those vague early symptoms and that grim prognosis, how do we actually arrive at a definitive diagnosis? And what can we even do to intervene? Well, the first thing to understand is that IPF is a diagnosis of exclusion. There's no single blood test or magic marker for it. It really takes a multidisciplinary team, we're talking pulmonologists, radiologists, and pathologists, all working together to carefully rule out every other known cause of this type of lung disease. And here are the key tools in their toolkit. The clinical picture often points to an older person, frequently with a history of smoking. But the real cornerstone of diagnosis is a high-resolution CT scan of the chest. We're looking for a very specific pattern called usual interstitial pneumonia, or UIP. This is characterized by scarring and honeycombing that's worst at the outer edges and the bases of the lungs. Then, pulmonary function tests will show that classic restrictive pattern, a decreased forced vital capacity, and, importantly, impaired gas exchange, which we see as a decreased DLCO. Now, once that diagnosis is confirmed, we can intervene. And while there's no cure yet, there are 2 frontline antifibrotic drugs that can slow the disease down. Nintedanib is a tyrosine kinase inhibitor, which means it blocks several of those signaling pathways that activate the fibroblasts. The other, pirfenidone, has broad antifibrotic effects, though we don't understand its exact mechanism quite as well. The key thing to remember is that these drugs don't reverse the damage. Their goal is to slow down the rate of new scarring.
And it's also really important to note that for eligible patients who have advanced disease, the only truly definitive curative therapy we have right now is a lung transplant.
All right, finally, let's just step back and think about how this progressive lung disease affects the rest of the body. It's a great reminder that no system in our body works in a vacuum.
This slide just perfectly illustrates how a primary respiratory problem creates a cascade of effects. Take the cardiovascular system. As the lungs' blood vessels get destroyed by scarring, the resistance goes way up, leading to pulmonary hypertension. This puts a huge strain on the right side of the heart. For the integumentary system, that digital clubbing we mentioned is an external clue to the chronic internal problem of low oxygen. And then you have the musculoskeletal system. The combination of the increased work of breathing and just being less active leads to significant muscle wasting and weakness. So let's quickly recap the entire journey we took today. We started with a healthy lung, defined by that thin, efficient interstitium. We then saw how in IPF, this out-of-control healing response leads to relentless scarring. That pathophysiology shows up in the clinic as progressive shortness of breath and those classic Velcro crackles. And finally, the logic behind our current treatments is to directly attack and slow down that underlying scarring process.
And that brings me to one final thought. We've defined IPF as a disease of healing gone wrong. So the big question for the future is this. As we get better and better at understanding the complex genetics and molecular pathways, could we one day move beyond just slowing the scarring and actually find a way to intervene and teach the lung how to heal correctly again?
Please remember, this information is for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Stay patho-curious, and I'll see you in the next A&P Live studio.